to talk to you about topical presbyopia treatment. This is something that we haven't really had a lot of, molecules and a lot of options. And I think that, when we traditionally think about presbyopia treatment, we often think about surgical options, such as with LASIK, with cataract surgery, with modern multifocal and trifocal IOLs. But today we're going to shift our focus to eye drops. These are my financial disclosures. So what exactly is the problem as we get older? Well, we all have seen our friends and family members, maybe even some of us have gotten to the point where we need reading glasses. And what happens is that in a young eye, the lens accommodates and allows us to focus on near objects. With presbyopia, the lens itself can't accommodate over time. And that, if you look at the graph on the left, pretty much around age 40, there is a more precipitous decline. And of course, decade by decade, it becomes more of an issue. How big is the presbyopia market? Well, when we look at our aging population, we're not seeing the same population maybe as we had seen from generations before. This natural aging phenomenon of the lens is occurring, but patients are less and less accepting of it and want additional solutions. There's currently, when this slide was made, there was no currently approved drug therapies. That has changed as of very recently. When we estimate the size of the market, so there's about 120 million patients, but the market size is has been estimated to be somewhere between $9 and $18 billion. So a very large market opportunity. And patients are very much motivated and interested to not have to wear reading glasses because it is really the hallmark of aging. So what are our current treatment options? Well, of course, glasses. You can go to the drugstore and see the racks of reading glasses, and there's 100 different options. Contact lenses for those that maybe have a history of wearing contacts, whether it's monovision or multifocal contacts. In the surgical world, I certainly spend a lot of time talking to patients about trifocal and extended depth of focus lenses, as well as monovision. But of course, there's some limitations. There's some risk of glare and halos, and it's not really an option for patients very early in presbyopia. So patients that are just starting to need reading glasses often don't prefer to have these implants. Refractive lens exchange, of course, is an option, but can be, an issue for patients from a cost perspective, but also, wondering whether or not it's worth taking on the risks of surgery. Corneal inlays have been around for some time now, but really haven't taken off. I think likely because there's some debate about whether or not the material is well tolerated, and I think future iterations will be promising. And then, of course, laser vision correction has been a staple for inducing monovision to treat presbyopia. So when we think about presbyopia management, it really needs to consider, that patients are doing things across multiple distances and different lighting. Even in our day-to-day as clinicians, optometry, ophthalmology, we go in the hallway, we're reading, our iPad to see what the patient's chart is. You come into the dimly lit exam lane. Every profession, every patient, whether it's work or social, has multiple demands for their near vision. And so, we traditionally define near as 16 inches. So being able to, like read a book or a magazine, iPhone, generation, laptops, we really think of that more as intermediate vision. And that's kind of that most common range where patients, when I ask them, that's a really important range to modern society. And so, when we go through and look at, then of course, going on to distance, patients really don't want to compromise if they don't have to. And so it's important to, think about where the patients are going to be in focus with whatever technology you choose. Pinhole or small aperture optics have been sort of studied and now employed to really allow the improvement in the depth of focus. So the pinhole effect, so decreasing the pupil size, can actually improve depth of field without compromising peripheral vision. And that's a really important concept as we think about some of these technologies and drops, et cetera, that are coming out. I thought I would add this information. This is the Burke Healthcare Research that did a survey of about 1,000 people in the US and just asking them about presbyopia and how they would feel about an eye drop. So patients have been surveyed in the past, but really asked about current technologies. And so it was about half male and female, a variety of income range. Some were using artificial tears at the time. Some had had prior surgery. And I think what was really interesting to see here is that 88% of the patients said that they have a strong interest in presbyopia correcting eye drops. And I think it's because patients, they find an eye drop to be relatable. Lots of patients, even without us knowing it, will pick up an artificial tear or some other drop that's over the counter, whether it's for allergies, et cetera. And the concept of an eye drop does not really freak them out like maybe surgery would. And so 88% of them said they would try it or probably try it, which I think is quite strong. And then, when we look across all the different demographics, it really is across a variety of patient populations where they feel like an eye drop would help improve them in terms of their comfort or their image. I think it's important for us to not forget about patient images, but we're all, in the generation of not wanting to look old by putting on reading glasses. And so I think, that's a really important thing to consider and not diminish in our patients. So what would the ideal treatment for presbyopia look like if it was a topical eye drop? Well, we want to balance efficacy, safety, and comfort. And so, patients are going to expect exceptional near vision acuity. They're going to want no reduction of distance vision or to have nighttime issues. And then, of course, having a high safety and tolerability profile is very important. Ideally, the drop should be comfortable and preservative-free. This is a little map here of the number of companies that are currently involved with or have a molecule to treat presbyopia topically. They're in a variety of categories. So starting with the left, so cholinergic agonists, specifically pilocarpine. So Allergan just got FDA approval for their eye drop called Vuity, which we'll review. It's 1.25% pilo in optimized vehicle. Eyenovia has both 1% and 2% pilo with a novel delivery mechanism. Orasis has a low dose 0.4% pilocarpine solution. And kind of moving to the other category of eye drops, Novartis has a lens softening drop, and Occuphire has a combination drop, which is currently in phase 2 trials of Nixol and pilocarpine 0.4%. And then up to the top, Visus has a solution called Brimochol, which is brimonidine and carbachol, and then a solution by Lens called aceclidine. And then just looking at it a different way in terms of, approvals. Aceclidine is a miotic, and it's currently in phase 2 studies. Allergan has received FDA approval for their molecule, but both Orasis and the Eyenovia products have completed phase 3 studies. And then the combination drop, Brimochol from Visus, is in phase 2 trials. Just to review the best-in-class presbyopia treatment parameters. So we want excellent vision, we want good efficacy and safety. We also want to think about durability. I think that's going to differentiate these class of molecules. So how long you put a drop in, how long does it last? We know that patients don't like putting drops in multiple times a day. And then, of course, how quickly its onset of action is. We don't want patients putting a drop in and saying, okay, well, like 2 hours later, now I can read. So I think that, ideally, something that's rapidly acting, that has a sustainable effect and is efficacious is what's going to win. But as in the next 15 to 20 minutes, we're going to review all these drugs that are in the pipeline as well as what has been FDA approved. So let's start with miotics, specifically cholinergic agonists. So when we look at presbyopia drops in the miotic category, what you'll see, of course, as you all are very familiar with, is that these drops shrink the pupil size to induce a pinhole effect. And we talked about how the pinhole effect allows focus lights, rays of light to be directly in focus on the retina. And so it'll sharpen both distant and near images. By increasing that depth of field and inducing that pinhole effect, compared to surgical options, I would say that, the pharmacologic effect is low risk, and it can be highly efficacious. It's reversible, which is also, I think, something that's very patient friendly and patient minded. But there can be some side effects in this category. The miotic drops can induce a headache, brow ache, can alter IOP, but it can also alter refraction with a myopic shift. And then, of course, something that's always important to patients is redness. So if you've ever had someone in clinic where, if you've done an LPI on someone, you put a drop of Pilo in, not all Pilo is the same, as we'll see with all these molecules. So let's start with Orasis, which is 0.4% pilocarpine. They have initiated their phase 3 studies. They have a parallel group study with both the active and the vehicle. And their primary endpoint is 3 lines of improvement in near visual acuity without loss of a line or more in best corrected acuity. That's an endpoint that's expected by the FDA. Secondary endpoint was 2-line improvement at near, as well as its impact on night vision and safety measures. And this drop is intended to be dosed 1 drop twice a day. They're going to have 600 subjects, and that's in 2 studies. And so we will await those results. Their phase 2B study, however, did report very positive results. You'll see here on the left, the proportion of subjects that had a 3 or greater line improvement compared to baseline was 47%. And that is remarkable. When you look at on the right half, the proportion of subjects that achieved greater than a 2-line improvement compared to baseline was 80%. So very efficacious drop. It had no negative impact on distance vision or night vision, which is really important. And then, assessed on the discomfort scale here, patients had, really minimal discomfort, and it was well tolerated, which is, I think, a very important attribute to these eye drops. So moving on to Eyenovia, this is a microline 1 or 2% pilocarpine that's delivered via the Optejet. So the thought is that the actual delivery of the medication and the amount of delivery is actually meaningful. And so this device actually, I'll show you in a video, will dose the eye in a microdose. So 8 microliter dose, which is teeny. And that really minimizes some of the side effects and increases the tolerability. And so they found that it has a low systemic drug absorption, excellent ocular tolerability. And I think I'll just show you what the device looks like. You can see here, so the typical eye drop is about 40 microliters. So this is, just a fraction of that, 1/5 the amount. And then when we look at their trial data, so their phase 3 Vision 1 trial achieved its primary endpoint, and statistically significant proportion of subjects achieved a 3-line or more improvement in their distance corrected near acuity. It was well tolerated, and they plan to have their Vision 2 study planned to wrap up and have top-line data in 2022. So this is a video of the actual Optejet technology. You can see that the patient opens the device and brings the device to their eye. And then if you watch here closely, you'll see that the medicine is gently sprayed, almost as if you're doing pneumotonometry. And so by the time the patient actually feels it and blinks, the medication has been delivered. So very novel drug delivery concept. So let's move on to the third miotic here. So this is Vuity, which was FDA approved. Allergan achieved this approval in mid-October. And so this is pilocarpine 1.25% with the pH or fast optimized vehicle. And what that technology does is if you tried to put a generic pilocarpine drop onto the eye, it has a very low pH, so it doesn't have great bioavailability or tolerability. This vehicle actually changes those properties and allows it to be tolerable on the eye, but also better absorbed. Nice little video here, seeing how the actual vehicle itself will change the surface pH to increase its bioavailability and comfort. So let's look at some of the data. So of course, the primary efficacy endpoint was a 3-line or greater gain at hour 3. And what you can see here is that the drop lasts about 6 hours, around 1 hour here. You can look at the bottom x-axis, and you can see that its greatest response is in about an hour, and then that slowly wears off over time. But it still met its endpoints out to 6 hours. When you look at the intermediate vision, this also has significant improvement in intermediate. And I think that's really important. We talked about how patients are doing both, intermediate and near activities. And what you can see here is that this effect is actually out to 10 hours. So they can expect to have intermediate vision for, quite a long time. Let's talk a little bit about dynamic pupil modulation. So what you can see here is that the pupil size does actually change by about 50-ish%. And that changes over time. And that really is what is driving its effect. The pupil does return back to normal for its baseline in 24 hours, and no tachyphylaxis was observed over 30 days. And I think that's important too. We want to know, is this a sustainable effect? And in all of these studies, I think we're all learning a little bit about this class of molecules and how they react. Pupillary response to light was actually maintained in both light and dark conditions. And I think that's very important because, if you think about a pupil shrinking, if it doesn't respond, if it's fixed, that's where people start to get symptoms such as, not feeling like they see as well in dim lighting. So the pupil remains dynamic. Vuity is safe and well tolerated. This is their safety data. And what you can see here is that really the AEs were very minimal. Eye irritation, some blur, increased tearing, but this is, and maybe here is another one to point out. So the incidence of headaches was 14%, but the vehicle had 9.4%. So I think this is yet to be seen in mainstream clinical practice. So we'll all have to test it out in our patient populations to see if the incidence of headache is significant or if it's more of a trial-related phenomenon. It is encouraging that 87% of the reported headaches were mild and transient and required no treatment. Let's talk a little bit about combination therapy. So this first product here by Ocuphire, so they've combined Nixol and 0.4% pilocarpine. And for those of you that are not familiar with Nixol, I had to look it up myself. So it's phentolamine, which is an alpha-1,2 antagonist. And so, it's been around, it's been improved a long time ago, but it has a novel mechanism of action on the iris dilator with a long durability, so up 24 hours plus. It also induces a little bit of pupil size reduction. It does not cause daytime redness, and it seems to be well tolerated. So in contrast, phentolamine is the iris dilator muscle inhibitor. Pilocarpine is a miotic, and it's an iris sphincter activator, so it causes pupil shrinkage. And pilocarpine as well has a long history, patients with glaucoma, patients needing a miotic for a certain reason. But the concentration, I think, is what's very notable here, 0.4%. That reduced concentration has the ability to potentially change the side effect profile of traditional dosage of pilocarpine at 1 or 2%. So potentially less headaches, less redness, less accommodative spasm. This is their clinical trial phase 2 design. You can see they had quite a number of arms. So they combined the phentolamine with the low dose pilo. They had just the phentolamine alone, the pilo alone, and then a placebo arm. So skipping to the data, you can see here that for the same primary endpoint that we've talked about, the combination eye drop showed 61% of patients actually had that 3-line gain or greater. And for their secondary endpoint of 2 lines or 10 letters, you can see that close to 80% of patients achieve that. Interestingly, Nixol alone definitely has some effect. The combination drop, its effect was durable over 6 hours. And when we look at what's happening with the pupil size, you can see here that there is some reduction in pupil just from using the phentolamine alone. But with the combination of the phentolamine plus a low-dose pylo, you can see that actually optimized the efficacy and actually provided the best mean pupil diameter as opposed to the single agents alone. They reported no serious AEs, no headaches or brow aches, which is really impressive. There was some mild transient redness in the combination group. And, I think that this is very exciting to see a combination eye drop. And clearly there's some improvement with the combination compared to the single agents alone. So going on to our last molecule here that we're going to talk about, it's the combination eye drop by Visus. So this is carbachol 3% and brimonidine 0.2%. And what you can see is that this molecule achieved a highly statistically significant reduction in pupil size and near vision improvement in ametropic phakic presbyopes that lasted out to 12 hours. So really a long duration of effect, which I think is amazing. And also no reports of headache or brow ache. And I think it's because this is, a different category of molecules. And so you can see here the combined different percentages of carbachol. So the 3% achieved a better pupil size. And when you look at it from an acuity standpoint, you can see patients had functional near vision out to 12 hours, which is really impressive. So how do we think about the mechanism of action of the single agent miotic versus Brimochol, which is a combination? And here, I think it's important to understand that carbachol is actually the most potent cholinergic for pupil constriction. But brimonidine is also important because that actually can kind of like lock in the pupil and prevent pupil dilation. It inhibits contraction of the ciliary muscle, which is important for mitigating side effects like ciliary spasm. It increases bioavailability of carbachol, which is really interesting that one molecule can potentiate another, but also it prevents the redness. We all know Lumify, which is brimonidine, is used to treat ocular redness. So this is a crossover study that supports that the contribution of each of the elements actually, the combination was better than each individual agent alone. You can see here the third line is that combination. And then, of course, correlating here again, the combination did better than any single agent alone in terms of acuity. I thought this was also really interesting. They did a study in pseudophakics. All this data that I've presented has been in phakic patients. And in 2018, a study was done looking at carbachol and brimonidine combination. And it was given to 30 pseudophakics. And what they found is that even the pseudophakics had an improvement, which was really interesting. So this has potential applications not only for our younger phakic patients, but also our older pseudophakic patients. So when we look, who might be the best candidates for eye drops? Well, emmetropes, I think, will be ideal. For patients to get their best utilization of this eye drop, they do have to be emmetropic. So whether that's, they come in emmetropic or if they wear contact lenses and then use the eye drop, so then they can wear single vision contact lenses. I think our post-LASIK patients would absolutely be very interested in an eye drop. It might even help with some of the halos or glare that patients sometimes get related to pupil dynamics after LASIK. I think hyperopes, so it will induce a little bit of vision correction. I think, of course, in the extremes of hyperopia, maybe not quite as much. And then pseudophakics. So, I mean, this is a really interesting population and one that also, doesn't like to use reading glasses. And I think that whether it's a primary treatment or something that's adjunct so that they can use the drop when they want to, when they're active or when they're out to dinner, etc. I think the watch outs, so, are high myopes. There have been some reports in the literature of pilocarpine inducing, potentially retinal tear. This is very, theoretical, and it's not something that has been well studied in the modern literature. So time will tell. And, for the same reason, if someone's had a retinal tear previously, might want to be cautious with these molecules. So to summarize, presbyopia treatment with topical eye drops is on the short-term horizon. We are so fortunate to have Allergan get FDA approval for their Vuity molecule. I think, once we can start using that molecule in our patients, we'll get a lot of firsthand experience about this category. But I think what's really interesting is that we're all getting an education on understanding pupil dynamics and miotic effects. But I really think that each of the other molecules that are on the horizon, should they be approved, have potential for adding into the space. And I think that as clinicians, what we'll probably find is that one molecule might work better for one patient profile and another for a different profile. And so, so exciting that we have a plethora of options. And I think that, forever forward, how we think about treating presbyopia, it will have changed. I think that there's, a practical aspect to being a clinician. Yeah. So not every drug and every patient behaves the same way as in the clinical trials. And so I think we'll really get a good education on who is in the sweet spot. I still absolutely think that presbyopia correcting IOLs, LASIK surgery, contact lenses, etc., all the treatments that I mentioned in the beginning of our lecture will all still have a place. And, of course, it's so nice to have an addition and not a subtraction. And so, I really see some of these technologies as complementary. And so, really in the end, it's going to be up to us to decide, based on the tolerability, the safety, and the efficacy on, who we use these drops for and who it can potentially have the greatest benefit. So with that, I thank you, and hope you enjoyed and learned something, and we'll have time for questions.
Hi guys, welcome back to the implementation track. I'm Dr. Seitz, and we're joined by Dr. Gupta live to answer some of the questions that you had regarding her presentation. Dr. Gupta, one of the things that the audience is really curious about is the side effects with Vuity. Can you explain what the side effects are? And specifically, are there headaches that come along as part of that profile?
Yeah, I think it's important to remember that this is a pilocarpine molecule, and while the pH fast optimization allows it to penetrate different, and so it's not like putting a drop of pilocarpine from the bottle in clinic into your eyes. There still is some headache, burning, some redness associated with it. I believe in the trials it's somewhere between 10 or 15% of patients get headaches. I think what's going to really bear out is our own clinical experience, to seeing how our patients are using it. Is it temporary? That's what I'm most excited for, is to kind of see, does the clinical trial data actually mirror what we have in practice? Because sometimes, the way the trial is designed or the way the patients are asked to document a certain question, there's not enough detail for us to really take that and apply it into our own clinical practice. But I do think with the entire class of miotic drugs, especially, the ones in the pipeline are not immune to this one as well, although there are a variety of different concentrations and delivery methods for future technologies that might be approved. But I do think that headache and some of that redness are probably the two things that our patients are going to talk to us most about.
And of course, with traditional pilocarpine, as we used to use it, one of the things that we were most concerned about was the risk of retinal detachment. So UT Michael Tran asked, were there any RD from the studies, or what percentage did we see in studies if they were there?
To my knowledge, there was no retinal tears or detachments. It's interesting, if you go back into the literature, it's actually very hard to find where some of that data came from. It's a very much a historical association, not to say that it's not real. I mean, there is, there's constriction, you could imagine, there's some tension on the ciliary body. And I think that, while I'm very reassured in the clinical trials that there was nothing related to a retinal tear, perhaps in our highly myopic patients, we might counsel them a little bit differently than we would maybe our hyperopic or, average refraction patients.
Sure, definitely be more maybe on the conservative side in those certain situations. And one situation that another audience member wanted to know about, Kingsley asked, is Vuity indicated, or I would say probably contraindicated, for a patient with closed angle glaucoma because of the pathophysiology?
Yeah, okay, good question. I hadn't really thought about that actually. So, I would think that if they have narrow angles, a miotic, if it's going to help constrict their pupil, might actually be helpful because you're, sort of uncrowding the angle, if you will. You remember in, of course, narrow angle patients, we worry about dilation in those patients because the iris gets moved out to the periphery and bunches up and can acutely block the drain. So I would not be worried about using a miotic in those patients, but those patients that have narrow angles often tend to have additional refractive error, and remember these patients they need to be made plano or like as close to plano as possible. So whether that's with contact lenses or refractive surgery, whatever it is, the eye drop will only be beneficial to those patients that have their baseline refractive error corrected. Of course, that said, there's millions and millions of patients that are, somewhere between -0.5 and +1 and don't wear glasses. And I think that's maybe the sweet spot of patient, but certainly the ones that are coming into our own practice will have to remember, to explain to the patients how the drop works, but also that, that they still will need their regular correction.
Sure. And then, of course, one of the main things you said, okay, yes, we have to actually put this in the clinic to see if it's actually going to have the effect that we want it to have. But the other barrier is cost, of course. Can we make this actually happen and make this a reasonable thing for clinicians to implement? So Jane wanted to know, have they addressed the patient costs yet?
As far as I know, it will be a self-pay product, like other molecules, like, for example, I think of like Latisse and eyelash growth. So something that's medical, but not necessarily treating a medical condition per se. So I don't know what the cost will be. I have not seen that from Allergan. I do believe that the medication will be available probably within the next month or so. First quarter 2022 is what I was had read somewhere, but absolutely cost will definitely be a barrier for some patients. I would love to see it being affordably priced where patients, will use it and at least try it. And so I think that, when we look at alternative options, certainly, when we think about dollar store readers and things like that. Certainly there's, I think, a patient willingness to incur out-of-pocket expenses, especially because this is, something that is pretty liberating, not have to carry around your readers. But I agree with you completely. It's going to be a little bit, interesting to see where the cost lands up. But also, I think it's interesting to also look at it from the practice perspective. Mm-hmm. I think a lot of our practices are going to be handling more phone calls. And I don't know, maybe, by offering it or being willing to talk to patients about it, it might drive more patients into the clinic that perhaps never had an eye exam. Not a lot of plano presbyopes come to the eye doctor. And so I think it'll be interesting to see both from a practice, but also patient perspective, how the finances all work out.
I just actually did a new multifocal fit for a plano presbyo, ametropic presbyo. And, thinking about that and keeping that in mind, definitely when I'm fitting multifocals, I have to think, is this patient going to be the right patient for this product? Do you already have patients in mind that you think, hey, this drop is going to be a good option for them? And if so, what does that patient look like, either from background or, like you said, prescription, maybe personality? What are your thoughts with patient selection for this medication?
Yeah, my practice is, fairly specialized with cataract and refractive. And so the first patient population is my LASIK patients, that are still fairly ametropic and are motivated to not wear reading glasses because, you know, they had a refractive surgery in the first place. So that to me is, you know, an easy patient population to introduce it to talk to. The other population is a lot of, and this is currently off label because it hasn't been studied, but I'm so curious to know if this will have an impact on my pseudophakic emmetropic patients. So the patients that said, oh, I didn't know I could get a multifocal lens at the time of cataract surgery, or, oh, I didn't get one because, you know, for whatever reason, but are looking for, you know, presbyopia correction. So that in my clinic, those two are probably going to be my first few patients I dabble with. But I think maybe an ideal, if you have more of a routine eye care practice, I think the ideal first patients to start on are ones that are close to emmetropia, ones that have realistic expectations. And by that, I mean, you know, this is an eye drop. It's not something that lasts forever. It requires them to take it. There's the potential side effects of redness, irritation, and headache. And so, you know, the patients that are not motivated, sometimes I think patients feel like, oh, well, should I have that? And, you know, I always like to talk to patients about, well, it's your choice, right? Because there are, you know, you can keep using your reading glasses. There's nothing wrong with reading glasses. But if you're tired of them or you want the freedom of, you know, being less dependent on them, then, you know, talking to them about this eye drop, I think is an easy next step. But I certainly would not want patients to feel like, oh, okay, this is going to get rid of my reading glasses forever and, you know,
right.
And change things.
And Brian, kind of talking about, you know, you said this is not going to last forever. Brian Kuma wanted to know, can it be used more than once a day for longer duration of effects?
So the medication, I believe if we look at the data slides, it lasts, you know, patients were getting intermediate vision out to about 10 hours. I think that, you know, it's something that we're going to have to wait and see clinically because the twice a day, you know, it's a miotic. So you kind of wonder, is that going to impact people's perception of their distance vision, right? If they're not getting as much light in because their pupil becomes smaller than what was studied in the trials. But I think that everybody is very different. We know that in clinical practice, no one has the same size pupils when they come in. And so I think it'll be more case by case rather than a blanket, yes, you can use it, you know, this many hours apart.
Okay, very good. All right. I think that wraps essentially on most of the questions. What, you know, you talked about the different methods. What are you looking forward to in 2022?
You know, I mean, first of all, this is, you know, amazing that we have an eye drop approved for presbyopia treatment. And I look at this as, you know, a complement to everything that we have. I'm still going to put in trifocal IOLs and extended depth of focus IOLs, and I'm still going to do LASIK on patients, you know, but this eye drop, I think, is going to be a bridge. You know, you asked about the sweet spot, those patients that are between 40 and 60, you know, or maybe even 40 and 50, 55. I feel like I see cataracts younger and younger these days. But I think I'm excited to offer something else for patients that, you know, will get them between starting presbyopia and then getting to cataracts. I also think there's going to be a lot of growth in this space. You know, from the presentation, you can see that there's several products that are out there, a few of them which are in phase 3 studies. And so, you know, if it's not 2022, it'll be early 2023, where we'll have hopefully even more products. And I love to see all the innovation and creativity, really. I mean, from a delivery methods, you know, taking a molecule, when I think about, oh gosh, pilocarpine, like really pilocarpine, you know, that for so many of these molecules, but we're going to see combination drugs. So taking advantage of both meiosis and other mechanisms against the iris dilator function. And then the novel delivery mechanisms, I think, are really, really cool because we've seen advances in drug delivery really change ophthalmology in so many ways, and how our patients, you know, dose and take medications. And so I think it's pretty cool that it's applying to presbyopia, which, you know, I think sometimes us as clinicians, we're kind of like, is that a real disease? Like, you know, I don't know. It's not, you're not dying. You're just wearing readers, right? But if we ask our patients, it's definitely a different perspective. It's more traumatic and jarring. Full disclosure, I'm not presbyopic yet. So I'm sure I will fully convert to complaining and being upset about reading glasses. But I think that all of the innovation in this space has sort of helped us understand and look at presbyopia as a real disease or as a burden, you know, upon society. And so I think I'm excited for all that's to come and for maybe us as eye care providers shifting our mindset.
Yeah, I agree with you in that. I think I've been really impressed with, you were saying, oh, it's pilocarpine. I mean, Cequa in the same way, you're like, okay, it's cyclosporin, but it's really been the delivery method in these new medications that have been really what's changing the game. And so I agree with you in that pharmaceuticals, I think, are exciting, and 22 will have a lot to offer for patients and providers alike.
Exciting times.
Well, thank you so much for, oh, there is another question or point. So I did want to bring that up. Vishal Madan said, research shows improvement of 3 lines or more. Can it be correlated to correction of +2 to +250 diopters of presbyopia correction? Please comment on this correlation. As an optometrist, it doesn't make sense in explaining to the patients. I think that that's what he's saying. If you need me to clarify that again.
Yeah, no, I think what they're saying is that, so in the study, they all had to be, I believe, emmetropic or like within a narrow window of emmetropia. And so I think what you're, maybe if I'm understanding the question, is what do the 3 lines translate to in terms of like diopters of correction?
I think so.
Maybe. Yeah, it's hard to know. I think there's a lot of factors that go into how someone reads without correction. So, you know, the vehicle of that molecule is also of that drug is really important. The vehicle is very lubricating, and, you know, we all know that dryness on the ocular surface, but also really just thinking of it like tear film quality. So if there's something that improves tear film quality, you're going to get an improvement in visual acuity. But also there's the miotic effect and the dynamic pupil modulation that's occurring with that the pilocarpine, and its delivery method. So I don't know that you can actually translate like a per diopter necessarily. The reason why, you know, 3 lines gain of or more is relevant is that that's what the FDA required to get approval for the molecule. So they deemed that a clinically significant result, which then, you know, meant that the patients were reading better than compared to just the vehicle, for example.
Wonderful. Thank you so much, Dr. Gupta, for joining us.
You're so welcome.
And attendees, thank you for joining as well. I'm going to give you a raffle code because you guys have been wonderful. I'm not going to put it in the chat. You know, I don't do that because you guys always tune in and have great questions for me to relay to our panelists. So the code that I'm going to say out loud is Oyster Point. Okay, it's all one word, Oyster Point. Very good.
Awesome.
Thank you.
You're welcome.
Housekeeping notes. After the show wraps, you'll be able to take your post-tests, submit course evaluations, and download the certificates that you obtained. Now, the post-test does require a passing grade of 75%, and it's going to ask questions about all the CE that was here during the program, CE or CME, whichever track you're applying for. That being said, you can take it multiple times, so don't stress out if you weren't able to attend every session and every lecture. Just do the best you can. You can take it multiple times. If you're hungry for more information, which I know all of our attendees always are, you can scroll down now and register for Eyes on Dry Eye 2022. I personally want to thank you guys for a great event. Like I said, this is my 2nd year hosting alongside Eyes on Eye Care. I love the company. They do great education, and it's really exciting just to see it grow and see all of us come together to collaborate and think about different things and hear different information and process it in different ways. So I just wanted to say personally, thanks for joining us today. For now, I'm going to say goodbye, but we're going to head right over to the exhibit hall for closing remarks with Dr. Matt Geller. Have a great rest of your weekend. Bye now.